comments. Now, I would like to introduce for the first speaker. He's the teacher of teachers and speakers of the speakers. I have learned a lot from him, and I'm sure every one of you have learned a lot from him. When he starts his talk, you just forget everything, even your cell phone, and then you just keep on listening to him because the way he teaches, everybody knows his name. I would like to introduce, and it's my honor as always to do that, so Professor Shahid Javed Akhtar Saab, all the way from Islamabad, has come to Karachi. For him, the introduction is the most difficult thing to do because he has done, mashallah, so much, but briefly, I would definitely like to share what he is doing today. His topic is clinical anatomy of face, and a brief intro regarding him. He has graduated from the Punjab Medical College, Faisalabad with distinction, obviously, who else? And then after that, he did his fellowship at FCPS in dermatology, and then he worked all his way till his retirement, pre-retired in 2020 as head of the department and as a consultant dermatologist. He has got the special interest in lasers, skin surgery, and contemporary dermatological teaching, as I just mentioned, in training his thousands of students all over Pakistan. He's actively involved in academic and research activities. We have all heard his talks in EADV and Dubai Dharma and many other conferences, and has many local international publications and presentations, and you can see his students all over the Pakistan. So please, the hall should be full of claps for Dr. Professor Shahid Javed Akhtar. The topic again is, I would like to say, the clinical anatomy of face. Thank you.
Thank you, madam. Thank you very much. For the guests, honorable colleagues, loving friends, thank you very much. And thank you, Dr. Najia, for your very kind words. In next 15 to 20 minutes, we will cover some basic concept of anatomy of face as is related to the injectors. This injection anatomy is slightly different from the classical surgical anatomy or the radiological anatomy, that it mainly resides on the understanding of the layered structure of the face and the surface landmarks. It's comparatively simple than the surgical anatomy and also simpler than radiological anatomy. And as a dermatologist, since we do not open the structures, we mainly rely on the topographic landmarks, and by getting clue, we then inject the deep structures. Actually, it's a blind process, but you definitely have in your back of mind that where you are going to inject. So wherever you have to inject, you have to know the basic underlying vital structures in order to avoid the side effects and in order to get the maximum benefit. Can I have these slides? Not really. Face is composed of the various layers, and as a dermatologist, we mainly deal with the epidermis and dermis and subcutaneous tissue, but as injectors, then we have to understand the deeper structures like the superficial musculo-eponeurotic structures and the deep fat and underlying skull. And the understanding of these layers is important, since when we are going to give botulinum toxin, we mainly want to target the SMAS, the superficial musculo-eponeurotic structures. And when you want to refill the deep fat pads, then you go to the deep atrophic area where you need to inject. नहीं वो चाहिए. Not working. Okay, आप यहाँ से change कर देंगे slides. Next. Next. We are really grateful to the organizers of this conference, and especially the next one. Next one. Especially the scientific committee headed by Dr. Sadia and her team. Really grateful for organizing this excellent scientific program. I owe great depth of gratitude to my teachers, late Professor Tahir Sair Haroon, the professor and the father of national dermatology. May Allah bless His endless mercy on him. The living legend, Dr. Manzoor Hassan, our great teachers, and we still remember and we are grateful for their teaching and training. The aging is process of getting older, and clinically that reflects on the surface by atrophic pigmented skin. Then the hypertonicity of the muscle lead to wrinkled appearance, and the atrophy of the fat and the shrinkage of skull leads to these sort of depressions. And for treatment of these, the epidermis, we can resort to some of the resurfacing methods like chemical peel laser or even topical continuous use of retinoids. The hypertonicity of the muscles, they can be relaxed with botulinum toxins. And for atrophy of deep fat and the shrinkage of bone, we can refill certain areas depending on where there is need for refilling. This is the basic concept of the layered structure of the face. Face is composed of 5 layers, starting from superficial, the skin, then is the subcutaneous tissue, then this is the mass where the muscles of facial expressions lie. And in case of botulinum toxin, we mainly want to target these layers. And deep to that is deep fat pads, and these fat pads atrophic with the advancing age. And all these layers, they are mobile to some extent on each other, but they are tightly united by fibrous band, we call them ligaments. They are true ligaments which are attached on the deeper side to the bone, and on the superficial side they intermingle with the reticular dermis. And these fibrous bands keep these various layers together, but at the same time allow certain degree of movement. This is the framework over which all the 5 layers of the skins, they lie. And the fibrous bands or the ligaments or the true osseous ligaments, they are attached to the orifices of this orbit, nasal, and oral. And by way of these attachment, you can get some mobility, but at the same time, they allow sliding of these structures onto each other. Again, the framework of the skull, over which all the layers they lie. And this is a dissection of the cadaver showing the superficial skin. Then deeper one is the subcutaneous fat and the mass, and deep to then, that is the deep fat pad. And these are the fat pads which become atrophic and that need to be treated with the fillers. The fibrous band that connect these various layers, they just resemble the branching tree. On the deeper side, they are attached to the skull, but as they move superficial, they branch and rebranch, and then they intermingle with the fibrous structure of the reticular dermis. And these fibrous bands, they keep these various layers together, but at the same time, they give you some mobility. This is again the cadaver dissection. The superficial layer of this face, the so-called epidermis and dermis, then is the superficial fat, this one, and this is thick on the cheek area, but it's thin over here, and then deeper lies the muscles of facial expression, and deep to them is the fat. And this layer structure is important when you are going to inject in these areas. And these are the various deep fat compartments. And these are bonded on each side. So whenever you inject the specific area, the injector material remain confined to these particular sites. So we have deep piriform space, then is the deep medial cheek fat pad, the medial SOOF and lateral SOOF, and these are the areas which we commonly inject. Again, showing the attachment of retaining ligaments, since we are short of time, so I skip quickly through these slides. And these are the very strong ligaments. The mandibular ligament, then this is the orbital retaining ligaments, and this is lateral temporal thickening. And these are the true osseous ligaments. So whenever you are doing cork thread, and in case of cork thread, you mainly try to uplift the superficial fat pad. So you use some anchorage point, and this orbital retaining ligaments, it's a good anchorage point where we can just above it, we can insert the cork thread and we try to lift this superficial fat. But please remember, you can only lift this superficial fatty layer. You cannot lift the smash, or you cannot lift the whole of the muscular layers of the face. So it's only meant to lift the superficial fat, which usually changes very little with the advancing air. It only drops down, and so you can lift it. But the so-called jowling has many factors. The main factor is the shrinkage of skull, then the absorption of fat, and then the sagging superficial fat. So with the so-called dermal threads, which we use as a dermatologist, you can only lift the superficial fatty layer. The muscles of facial expressions, again, the wrinkles, they appear at right angles to their movements, and these are the common muscles of facial expressions. And this is the action of movements. And since we dermatologists, we mainly rely on the topographic landmarks, so it's important to know about these. Volume.
Here, we're going to look at the surface anatomy for the chin
Previous
when
one.
she contracts
Previous one.
Here,
Previous one.
we're going to
और पीछे जाएं. Next.
Let's have a look at some of the surface anatomy of the muscles involved in upper face botulinum toxin treatments. The first muscle we will look at is the frontalis muscle. And the frontalis originates from the galea aponeurotica and then inserts into fibers of the procerus, corrugator and orbicularis oculi muscles near the eyebrows. The action of the frontalis is a brow elevator. It is important to notice that it's the only brow elevator in this region. Accordingly, if we overtreat this muscle, we can get some brow ptosis. In some patients, there is a galea in the midline and an absence of muscle fibers in this location. In terms of the lateral extent of the frontalis muscle, if we palpate the temporal fusion line or the temporal crests, which are usually found at the outer third of the eyebrow, it's very rare to have frontalis fibers lateral to this point. Accordingly, we normally inject within the temporal fusion lines on both sides of the face. The next muscle to look at is the procerus. The procerus arises from fascia arising from the nasal bones and nasal cartilage. The fibers ascend vertically and insert into the lower fibers of the frontalis muscle and also the skin in between the eyebrows. Its action is one of a brow depressor, and when it contracts, it will bring the heads of the eyebrows down, like so. And you will notice this transverse crease across the bridge of the nose, and this is due to procerus activity. The next muscle we have is the corrugator supercilii. The corrugator arises from the superciliary arch of the orbital rim, and the fibers ascend at a 30-degree angle to insert into the dermis after passing through fibers of the frontalis. When we contract the corrugator, we will often see a little dimple near the insertion of the corrugator in the dermis. Finally, we have the orbicularis oculi muscle. The orbicularis oculi muscle has three parts, a preseptal and a pretarsal part, which are involved in involuntary blink movements of the eye. And then there are also the orbital fibers, which are involved in voluntary eye closure. The orbicularis oculi is a very thin muscle lying just under the skin. If the patient forcibly closes their eyes, you will notice that as the muscle is radially orientated, it forms lateral canthal lines which are perpendicular to the muscle fibers like the spokes of a wheel. We can also get the same lines forming when a patient smiles excessively. Accordingly, we treat this muscle for excessive crow's feet formation. We can also see the zygomaticus major muscle here. This originates from the maxilla and inserts into the modiolus and is an elevator of the corner of the mouth. Because the origin of the zygomaticus major is very close to the lower portion of the crow's feet, we have to be very careful injecting in this area